If morphine is the drug everyone else gets compared to, fentanyl is the drug you'll actually reach for in almost every single case you run. It didn't come from a poppy plant. It came out of a lab in 1960, built by chemists at Janssen Pharmaceutica, who were trying to design something faster, stronger, and more controllable than anything nature had given us. They succeeded so completely that fentanyl is now woven into nearly every anesthetic you'll ever give. Let's take it apart. What kind of drug this is. Fentanyl belongs to the phenylpiperidine family, structurally related to meperidine, and it's the parent structure behind sufentanil, alfentanil, and remifentanil. Potency-wise, it lands somewhere between 75 and 125 times stronger than morphine, depending on the study you're reading. The defining physical property of this molecule is how fat-soluble it is. That single characteristic is going to explain nearly everything unusual about how this drug behaves, so keep it in your back pocket as we go. How it works. Same receptor story as morphine. Mu receptors dominate, kappa contributes a little, delta barely at all. Activating those mu receptors gives you the effects you want: analgesia, sedation, a blunted stress response to surgical stimulation. And it gives you the effects you have to manage: slowed breathing, a slower heart rate, and one complication that's essentially unique to this drug, which we'll get to shortly. Why it hits so fast. Give fentanyl IV and you'll see onset within 1 to 2 minutes, peaking somewhere around 3 to 5 minutes, with a single dose running its course in roughly 30 to 60 minutes. The speed comes directly from that lipid solubility we just mentioned. Fentanyl slips across the blood-brain barrier far more readily than morphine ever does. Why it stops working so quickly. Here's something that trips up a lot of trainees. A single fentanyl bolus doesn't wear off because your body metabolized it that fast. It wears off because the drug physically moves somewhere else. After injection, plasma levels spike. Fentanyl rushes into the brain. And then it starts leaving the brain again, migrating into skeletal muscle, fat tissue, and lung tissue. As the drug spreads out into these inactive storage compartments, plasma levels fall, brain levels fall with them, and the analgesic effect ends, long before the liver has done any meaningful metabolic work. That's redistribution, and it's the whole reason a drug this potent can still have such a short clinical window after one dose. The lung reservoir, something fentanyl does that morphine doesn't. Here's a genuinely fascinating quirk. Roughly 75% of an initial fentanyl dose gets temporarily soaked up by the lungs on its very first pass through the pulmonary circulation. The lungs essentially act as a holding tank, buffering the initial spike in plasma concentration and slowly releasing drug back out over time. Morphine doesn't do this to any meaningful degree. This pulmonary uptake shapes fentanyl's entire pharmacokinetic behavior, and, as we'll see later, it may explain one of the more unsettling things that can happen after surgery. Distribution. Fentanyl is heavily protein-bound, somewhere around 79 to 87%, and it distributes into an enormous volume of distribution, roughly 4 liters per kilogram, or about 335 liters total in an average adult. That massive volume reflects just how extensively fentanyl accumulates in muscle and fat, tissue that has no pharmacologic use for it, but happily soaks it up. What the liver does to it. The liver clears fentanyl almost entirely through CYP3A4, producing a metabolite called norfentanyl. Unlike meperidine's troublesome metabolite, norfentanyl carries almost no pharmacologic activity of its own. It's simply an inactive breakdown product. Less than 10% of fentanyl exits the body unchanged through the kidneys. The vast majority gets handled by hepatic metabolism first. The half-life that confuses everyone. Terminal elimination half-life runs 3 to 6 hours. And this is where a lot of people get genuinely confused. How does a drug that only lasts 30 to 60 minutes clinically have an elimination half-life measured in hours? Because those two numbers are answering completely different questions. Clinical duration after one dose is governed by redistribution, the drug leaving the brain for muscle and fat. Elimination half-life reflects something different, how long it takes the entire body burden of drug to actually get cleared, which depends on that huge volume of distribution and how slowly peripheral tissue releases the drug back into circulation. Duration and elimination are not the same conversation. What happens with repeated dosing or an infusion? This next concept might be the single most practically important one in this entire lecture. Context-sensitive half-time, the time it takes plasma concentration to fall by half after you stop an infusion, behaves very differently depending on how long you've been running that infusion. Stop a short infusion and recovery is quick. Keep the infusion going for a long time, and fentanyl progressively loads up those muscle and fat reservoirs, turning them from a place the drug briefly visits into a place it starts accumulating. Once those tissues are sufficiently saturated, they start releasing drug back into the bloodstream, even after you've turned the infusion off, and recovery slows dramatically. Push an infusion past roughly 2 hours, and fentanyl's context-sensitive half-time actually surpasses sufentanyl's, a genuinely counterintuitive fact, given that sufentanil is the far more potent drug. This exact problem, unpredictable recovery after long infusions, is part of why remifentanil, with its unique organ-independent metabolism, became so attractive for lengthy procedures. Dosing across different uses. Low-dose analgesia, somewhere around 0.5 to 2 micrograms per kilogram, IV. Blunting the sympathetic surge that comes with laryngoscopy, intubation, or surgical stimulation. 1 to 2 micrograms per kilogram IV, scaled to how much suppression you need. High-dose fentanyl technique was historically the primary anesthetic for cardiac surgery, prized for keeping hemodynamics rock steady with essentially no myocardial depression and no histamine release. Neuraxially, intrathecal doses run around 10 to 25 micrograms, often combined with local anesthetic in labor epidurals, where it speeds analgesia without adding much motor block. Transdermally, patches deliver anywhere from 12 to 100 micrograms per hour, with peak plasma concentration not arriving until roughly 18 hours after application, and each patch running for about 72 hours total. That slow onset is exactly why patches are inappropriate for acute pain, and exactly why opioid-naive patients starting a patch need close monitoring. Breathing. Fentanyl blunts respiratory rate, tidal volume, and the brain's normal response to rising CO2 and falling oxygen. Here's a pearl worth remembering carefully. Respiratory depression can outlast the analgesia itself. Some patients show a second rise in plasma fentanyl levels well after surgery, possibly from that pulmonary reservoir finally releasing drug back out, or from other tissue compartments slowly giving it up. This secondary peak may explain why respiratory depression sometimes shows up later than anyone expects, well into the postoperative period. The heart and vessels. Unlike morphine, fentanyl essentially doesn't trigger histamine release. That single difference carries huge clinical weight. Minimal vasodilation, minimal hypotension, and essentially no direct myocardial depression. Bradycardia shows up regularly. That's the cardiovascular effect you actually need to watch for. Blood pressure tends to stay remarkably stable. This exact combination, stable pressures, preserved contractility, no histamine surge, is precisely why fentanyl became the backbone of cardiac anesthesia for so many decades. The complication that's almost unique to this drug. Give fentanyl fast enough or in a large enough dose, and you can trigger chest wall rigidity, sometimes called wooden chest syndrome. The muscles of the chest wall, and sometimes the jaw, stiffen to the point that ventilating the patient becomes genuinely difficult. Airway pressures climb, and bag mass ventilation can become nearly impossible. Risk climbs with rapid administration and large doses. Management: neuromuscular blockade to break the rigidity, positive pressure ventilation to support oxygenation in the meantime, and occasionally naloxone, though that carries the obvious trade-off of reversing your analgesia too. This is a genuinely distinctive fentanyl complication, one that boards love to test, and one you'll want to recognize instantly if you ever see it in the room. Intracranial pressure. The older teaching held that opioids as a class raised ICP. Studies did find modest ICP increases after fentanyl, but the more likely explanation runs through an indirect pathway. Systemic hypotension triggers reflex cerebral vasodilation, which drops cerebral perfusion pressure and can secondarily nudge ICP upward. Current practice generally treats fentanyl as acceptable in neuroanesthesia, as long as ventilation and hemodynamics are being carefully controlled throughout the case. How it interacts with your other drugs. Fentanyl shows powerful synergy with benzodiazepines, propofol, and the volatile agents. Used deliberately, that synergy is a gift. It lets you drop the dose of everything else, while improving analgesia across the board. Used carelessly, that same synergy becomes the risk. Stacking these drugs on top of each other can produce far deeper respiratory depression, and a much slower emergence than any single drug would predict on its own. The common side effects: respiratory depression, bradycardia, nausea, vomiting, sedation, pruritus, constipation. This is the standard opioid side effect list you'd expect. And then there's the pair that's genuinely distinctive to fentanyl: chest wall rigidity and delayed respiratory depression after the fact. Who needs extra caution? Watch closely in severe respiratory disease, obstructive sleep apnea, elderly patients, anyone on other CNS depressants, hepatic impairment, opioid-naive patients starting a transdermal patch, and elevated ICP, where careful control of ventilation and hemodynamics matters most. Stacking it against the other synthetic opioids. Fentanyl, 75 to 125 times morphine's potency. Onset 1 to 2 minutes. Duration 30 to 60 minutes. Minimal histamine release. Sufentanil sits far above it. 500 to 1,000 times morphine's potency. Onset 1 to 3 minutes. Duration 20 to 45 minutes. Remifentanil comes in at 100 to 200 times morphine's potency. Onset about 1 minute, but a duration of only 5 to 10 minutes. That ultra-short window comes from its unique metabolism by plasma esterases, completely independent of the liver and kidneys. Morphine and hydromorphone lag far behind on speed, but both trigger more histamine release than any of the synthetic phenylpiperidines. The high-yield summary. Fentanyl runs 75 to 125 times more potent than morphine. Its speed comes from extreme lipid solubility. Onset is fast, but full brain-level effect takes about 6.4 minutes to catch up. A single dose ends because of redistribution, not metabolism. Roughly 75% of an initial dose gets temporarily parked in the lungs. It causes essentially no histamine release, a defining contrast with morphine. Bradycardia shows up more often than hypotension does. Context-sensitive halftime climbs steeply the longer an infusion runs. Transdermal patches take about 18 hours to peak and last 72 hours total. Chest wall rigidity is essentially a signature fentanyl complication, and it works synergistically with benzodiazepines, propofol, and volatile agents, a genuine advantage when managed deliberately. Pulling it all together. Fentanyl, a synthetic molecule engineered for speed, potency, and hemodynamic stability. Understand redistribution, and you understand why a single dose feels short-lived. Understand context-sensitive halftime, and you understand why a long infusion behaves nothing like a quick bolus. Respect the lung reservoir, respect chest wall rigidity, and never confuse its short clinical duration with a short elimination half-life. Those are two completely different stories. I'm Anesthesia Buddy. Stay sharp. See you in the next one.